I will give a talk now about oxygenation of the newborn. We call it "What do we know and what remains unknown." Just want to start out a little bit with a little bit history of oxygen. And oxygen was discovered as an element by the Swedish pharmacist Scheele in 1772, and independently of him, Priestley 2 years later described oxygen as an element. And very quickly, oxygen was used in newborn care. Already at the end of the 1790s, it was used to newborns with respiratory problems. And as you know, for 200 years it was not questioned to use 100% oxygen during newborn resuscitation. And I mentioned in my first lecture that in 1992, American Heart Association underlined that there's no reason to be concerned about giving 100% oxygen during the brief period of a newborn resuscitation. Well, we started to question that, and in 1993 we published a pilot study from Delhi, New Delhi, where we had pseudo-randomized newborn babies who needed positive pressure ventilation to air or 100% oxygen. And in fact, Siddharth Ramji, I know that many of you from India know Siddharth Ramji. He was standing here at this podium in 1992 and presented these data for the first time at the ESPR meeting here in Uppsala. In 1998, we published a RESER-2 study where we had randomized more than 600 babies from 10 centers from 6 countries: India, Philippines, Egypt, Spain, Estonia, and Norway. And we were able to show that it's possible to resuscitate babies with air, and there was also a strong tendency to improve or reduce mortality in babies who had received air. And then a few years later, 2003, 2004, the first meta-analysis were published, and then it was shown that babies who were resuscitated with air had a significant lower mortality, 30% reduction in mortality compared with those who received 100% oxygen. So in 2010, as we mentioned already earlier today, ILCO changed their guidelines from 100% oxygen to air for term and near-term infants. And they also warned against using too much oxygen for preterm babies. And also in 2010, we got Dawson curves for how oxygen saturation develops the first 10 minutes after birth. So what are the goals of oxygen therapy when you talk about newborn care? First of all, it is to provide sufficient oxygen to the tissues in order to avoid anaerobic metabolism. It's also important to promote an optimal brain and somatic growth, and to prevent hypoxic pulmonary vasoconstriction. And as every neonatologist knows, is that it's also important to minimize adverse effects of the use of oxygen, because we all know that oxygen is critical to life, but too much oxygen in a newborn can cause oxidative stress, and it may induce lung injury and lung disease as bronchopulmonary dysplasia. Also ROP, we know, is associated with high oxygen, and also can lead to brain damage, impaired brain development, and damage to the heart, kidneys and other vital organs. So if we look at the world map for newborn resuscitation, we're talking about oxygen. The world map looked something like this. Before 1998, before the RESET-2 study was published, all the guidelines recommended to use 100% oxygen. In 1998, actually the World Health Organization changed, and they started to recommend to use air for newborn resuscitation based on on the RESET-2 study results. Now, what happens if you resuscitate a newborn baby, asphyctic baby with healthy lungs with 100% oxygen? Probably the same as they found here in Sweden. Richard Linner and co-workers, where they tested this out in newborn lambs. They had induced cardiac arrest, and then they randomized animals to be resuscitated with either 100% oxygen, the red line, or air, the blue line. And you see that if you resuscitate with 100% oxygen, you get this enormous PO2 peak. This is in kilopascals. It's you multiply with 7.5, you get it in millimeter mercury. By contrast, if you resuscitate with air, you get this more slow but physiological normalization of PO2. Now, last year, actually a year ago now, this book was published from Oxford University Press. 50 studies every neonatologist should know. And you see the editors here, Susan Hay, Roger Saul, Barbara Smith, Harish Kirpalani, and John Supancic. And actually the first study they are discussing in this book is the RESET-2 study. So they summarized the RESET-2 study like this. It showed it was possible to allocate newborn infants to 2 different resuscitation strategies in the seconds following birth. It facilitated further studies to answer this question with higher methodological standards. It provided a template to address other important questions to fill the evidence vacuum of delivery room care, and the findings themselves led to important practice change, saving countless lives around the world. What about preterm infants? Because if you look at, this is the RESET-2 trial profile, we only included term and near-term infants in this study. Here we have all the centers participating. I'll come back to preterm in a moment, but just some of the data from the RESET-2 study. Here we have the heart rate, how heart rate developed, and you can see there was no difference in babies who were resuscitated with air or 100% oxygen. There was also no difference in blood gases or acid-base balance. However, when we looked at the APGAR score, there was, you see that the room air have the open squares and oxygen the shaded squares, and you see that actually there was a strong tendency to higher APGAR score in babies resuscitated with air. And this has also been confirmed in later studies. And the reason for that is probably kind of a completely new discovery, was that those babies who had been given 100% oxygen, they took their first breath in median 30 seconds later than babies who had been given air. So it seems that oxygen depressed the ventilation of the babies. And this may explain why there was a difference in the APGAR score. And in meta-analysis, we have seen that there is a difference in APGAR score also at 5 minutes of age. We looked at, this is the primary outcome, death and or hypoxic ischemic encephalopathy, and there was no difference in the outcome. When we looked at death within the first 28 days, it was almost significant in favor of room air, but it was not significant. So the conclusion of the RESET 2 study was that it had demonstrated significantly improved survival by using room air instead of 100% oxygen. However, it indicates that resuscitation of asphyxiated newborn infants can be performed with room air just as efficiently as with 100% oxygen. That was our conclusion. We didn't draw any conclusion that air was better than 100% oxygen. But, as I mentioned, room air babies recovered faster than babies resuscitated with 100% oxygen. The RESET 2 study had several limitations. It was not a truly randomized study. It was a pseudo-randomized, randomized by date. It was not blinded. But we think that it represents a first step in evaluation of newborn resuscitation routines, also in general. And the study itself didn't justify changes in routines, I think. I mentioned that the meta-analysis were published. This is a meta-analysis we published in 2008. Now there are 10 studies we have been able to identify, randomizing or pseudo-randomizing babies to receive air or 100% oxygen. And now we can see here, as I mentioned, that mortality is significantly reduced in favor of room air. And in 2010, ILCOR changed their recommendation, stating that in term infants receiving resuscitation at birth with positive pressure ventilation, it is best to begin with air rather than 100% oxygen. So we try to illustrate some of the findings here. This is Satyan Lakshmanushma, many of you know. He's also an excellent, in addition to being an excellent neonatologist and researcher, he is also an artist. So he has illustrated, so here's the PO2 development in babies given air, and some free radicals are generated. But if you resuscitate with 100% oxygen, you get this enormous PO2 peak, as I've shown already, and you get this, we'll call it a tsunami of free radicals. And we know now from animal and clinical studies that hyperoxia leads to cerebral vasoconstriction and even brain inflammation. And by contrast to what everybody said, told me, pulmonary vascular reactivity is increased, because whenever I gave talks in the 90s and about this issue, people stood up and said, we have to give these babies oxygen in order to dilate their pulmonary vessels. And it's been shown later that exactly the opposite happens, that you get more pulmonary vasoconstriction. And it's been shown also damage to the heart and the kidneys by hyperoxia. It's also been associated with malignancies, hyperoxia. So in 2019, this meta-analysis was published from US, Welsford and co-workers, and basically they confirmed what we had found earlier, and they also said there will unlikely be any further studies on this topic. Well, I'm not so sure about that. Some of these studies, the RESET 2 study and some of the first studies by Max Vento, they were not optimal. At that time, we didn't monitor the resuscitation with the pulse oximeter. There's also another change in our routines, and that is we are now practicing delayed cord clamping. So anyway, resuscitation with air seems to reduce mortality. But that is for term and near-term infants. What about preterm infants? And here I just want to show you some of the biochemical background for the idea to avoid oxygen during resuscitation. And this is from a study I did with a colleague of mine for many, many years ago now, end of the 70s, in endotoxic dogs. We did these studies for other reasons. We are not interested in resuscitation, but I asked my colleague, could you allow me to resuscitate these animals when they are terminal? And he said yes, and then I measured hyperxanthine, and you see how there's enormous exponential increase in hyperxanthine within a few minutes, actually. And at that time we knew that hyperxanthine, which is a breakdown product from ATP, is also a potential oxygen-free radical generator. So when you give oxygen superoxide radicals are generated. And then it was quite easy to kind of assume that if you have a situation where you have a lot of hyperxanthine in the tissues and you give oxygen, you may have an explosion of oxygen-free radical production. So that was the background for that. So based on this, we did a lot of animal studies, piglet studies. We had developed a piglet model with 1 to 2 day old piglets, and we made them hypoxic, and we reoxygenated them with different oxygen concentrations. Here are 2 of my fellows, Jannik Andresen and Renaud Solberg. And I'm not going into details, but here you can see how the PO2 is dependent on the FiO2, and you see it's increasing linearly, at least with the PO2 is increasing linearly with FiO2. But also the hydroxyl radical formation increases, follows the same pattern. The higher FiO2, the more hydroxyl radicals are generated. And the same, we looked at DNA damage, and pure oxygen is clearly damaging to DNA. So that was term babies and some animal experiments. But what about the very low birth weight infants, the preterm infants? And I will just quickly show you some of the first results. In 2008 and 2009, the 2 first studies in this topic was published. The first was from Neil Finer's group in San Diego, Wang and co-workers, and they resuscitated babies less than 32 weeks with either air or 100% oxygen. And the year after, Max Vento, he published babies, I think it was less than 29 weeks, with either 30% or 90% oxygen. So here we have the data from the Wang study, and what you can see here is that heart rate was actually not affected by the oxygen concentration. Seems to be very similar, but when you looked at the need of oxygen, you can see that the babies, the lower curve here, they needed the upper curve here, they needed a lot of oxygen. And when we looked at their oxygen saturation, you see that the babies resuscitated with air, they had a very low oxygen saturation for several minutes. So these authors concluded that these babies, they need more than room air. And then Max Vento's study, babies less than 29 weeks, randomized to receive 30 or 90% oxygen, and again there was no difference in the heart rate, and there was only difference in FiO2 the first 4 or 5 minutes. But what he found was that those babies who had been resuscitated with 30% oxygen, they had less oxidative stress, less inflammation, and also chronic lung disease they found in this study. There was no difference in the saturation, so that was interesting. But when they looked at oxidative stress markers, as they did here, you can see that even at day 3, there was increased oxidative stress in babies who have been resuscitated with 90% oxygen. And they also found higher TNF-alpha in the babies resuscitated with 90% oxygen, also interleukin 8. And then Julie Owe, she was the PI of a study, multi-center study, where testing out babies less than 32 weeks. They were randomized to air or 100% oxygen if they needed positive pressure ventilation in the delivery room, and there was no difference in mortality when they looked for all babies. Do you need this? No. However, when we did post-hoc analysis of babies less than 28 weeks, we saw that there was a higher mortality in babies who had received air compared with 100% oxygen. You see the relative risk 3.9. So this was highly significant. Another finding here was that we looked at babies who reached saturation of 80% within 5 minutes, and they had much lower primary outcome, which was death or disability, 50% reduction actually. And when we did a follow-up study of these babies, we saw that those babies who had not reached a saturation of 80% within 5 minutes had a 5-point lower cognitive score than those who had reached a saturation of 80%. And there also were more interventricular hemorrhage in those who did not reach a saturation of 80%. So for that reason, it's now been recommended that these babies should reach a saturation of 80% within 5 minutes. This is a meta-analysis we carried out, the same topic. We looked at high versus low FiO2 in preterm babies less than 32 weeks, and there was no difference in mortality, but we see difference in, as I mentioned, in cognitive score and etc. And now this is the question: should we start with a low FiO2 and titrate it up if needed, or should we start with a high FiO2 and titrate it down? Well, we tried to look at this, and together with Julie Owe, we have followed 700 babies less than 32 weeks, who all of them needed resuscitation in the delivery room, and we stratified them according to gestational age and initial FiO2. So some of them were resuscitated with air, some with 30% oxygen, 60%, 90%, and 100% oxygen. And here, what you can see here is that, I need to change them. So here we have the whole cohort, and the upper panel here is for all infants, and the shaded area is the recommended saturation range, the first 10 minutes given by the American Heart Association and also some European guidelines. And what you can see here is that babies who receive air, they are under this recommended area. And especially if you look at the lower, the C panel, you see that also it takes many minutes before they reach a saturation of 80%. So here we looked at the data. I looked at babies who received 90% to 100% oxygen, and these are babies, I think these are all less than 29 weeks, and it takes between 3 and 4 minutes in median to reach a saturation of 80%, 3 3.6 minutes. Babies who receive 30% oxygen, it takes 6 minutes to reach a saturation of 80%. And this indicates that 30% is not enough for these babies if we want them to have a saturation of 80% within 5 minutes. Now, another issue came up based on some animal studies in premature rabbits. It was from Australia, showing that these animals had a glottic closure, and in order to open the glottis, they needed some oxygen, just a dash of oxygen. And maybe also newborn babies, immature babies, need to open the glottis by be given some extra oxygen. But if this is the case, at least I would say that it should be as low and brief as possible. So how much oxygen should we give? Well, this was tested out in a study by Janneke Dekker and Ariane Tepas in babies 29 weeks or lower. So they were ventilated with 100% versus 30% oxygen. And so what they found was that the babies who were given 100% oxygen, they had a higher minute volume, they had an improved oxygenation, they had a shorter duration of mask ventilation, and they didn't find any increased risk of oxidative stress, as Max Vento had found 10 years earlier, but they didn't follow the babies very closely. Here I have looked at the data from Dekker, and what you can see here is the green line are babies resuscitated with 100%, and the yellow or orange line, those are resuscitated with 30% oxygen. So if we give 100% oxygen, it takes in mean 4 minutes to reach a saturation of 80%. But as we found in Julie Ovi's study, it takes between 5 and 6 minutes if you start out with 30% oxygen. But here I have compared the development of oxygen saturation in the Ovi population versus the Dekker population, the same gestational age. And what you see here is that the Dekker baby, the orange line, they start out much lower than the Ovi baby for some reasons. We don't know why. They start very low. And when you look at, this is for babies being given 30% oxygen, and if you look at the babies who are given 90 or 100% oxygen, the same, the Dekker babies start much lower, and that indicates that maybe as important as which initial FiO2. And Vissel Kapadia, he looked into the same cohort of 700 babies and looked at the outcome of those babies who did not reach a heart rate of 100 beats per minute. And he talked about transient bradycardia, if the heart rate was less than 100 beats per minute for less than 2 minutes, and prolonged bradycardia if it was more than 2 minutes. And what you see here, if you look at the combination of prolonged bradycardia and not reaching a saturation of 80% within 5 minutes, increases the risk of bradycardia, of mortality 18-fold, enormous increase in mortality. And even here you can see transient bradycardia also increases the risk of mortality 10-fold. Prolonged bradycardia combined with reaching a saturation of 80% at 5 minutes also increase the risk. So it is important to avoid bradycardia. Now, in order to get a step further, we did this net motion analysis. We did a so-called individual participant data network meta-analysis, and using the same data, and this was published last year in JAMA Pediatrics. So in this study, we compared babies who had been given intermediate oxygen, 50 to 60 or 65% versus low oxygen and low oxygen, 21 to 30% versus high oxygen, 90 to 100% oxygen. And here we have the demographics, and you can see that we have in these three groups, we see that the birth weight is very similar, a little bit less than 1,100 grams, and gestation age 28.5 in all these the groups. So what we found was that high versus intermediate, and this is mortality to hospital discharge. So high versus intermediate seems to favor high. High versus low significantly favors high. And intermediate versus low, we didn't find any difference. So, yeah, I skipped this. So the conclusion of this net motion study was that a higher initial FiO2 is possibly associated with reduced mortality compared to intermediate initial FiO2, but this has a very low certainty, and we need more evidence. But this is the basis. Someone asked me in the break why we recommend 60% oxygen in the new European guidelines for babies less than 28 weeks. It's based on these studies here. So here is a summary of the net motion study. Initiation of resuscitation with high oxygen, 90 to 100%, is associated with lower mortality compared to low, 21 to 30%, and intermediate, 50 to 65%. So just some take-home points at the end, the harms and benefits of oxygen for the preterm infant in the delivery room must be managed meticulously. Additional evidence is urgently needed, especially during the first few minutes of life, when the infant's physiology is changing at its most rapid pace. High initial FiO2 is possibly associated with reduced mortality compared to intermediate initial FiO2. For preterm infants less than 28 weeks gestation, 30% oxygen is probably too low. And as you remember from my previous lecture, ILCO now recommends 30% and more for these babies. And 90 to 100%, in my opinion, is probably too high. Not everybody will agree with me in that. So this is my personal view. There are some ongoing trials. We haven't gotten all the results from trials testing out 30 versus 60%. I suggested, this was at the PS meeting last year, to start with 40 to 60% in babies less than 80%, less than 28 weeks, and now the European RDS guidelines ended up with 60%. This can of course be discussed. It's doesn't have a very strong evidence. It's important to titrate to achieve a saturation of 80 to 85% within 5 minutes. So when we're talking about oxygen in the delivery room, we are talking about the Goldilocks principle. This was introduced by Vishal Kapadia, again in a recent study, or some years ago now. We have to find just the right amount. The question is, and it's still an open question, when is it too little or too much and just right? So with this, I would like to thank my co-workers, international co-workers, Max Vento, Satan Laxman Rushima, Julie Ovi, and Vishal Kapadia. And I will thank you for your attention. And here are some references for those who are interested. And for those who would want to read more about this, in my book, Fighting for Air, is also in Swedish here, but you can find it on Amazon.com. Thank you very much.